Anita, are you there? Anita?
Oh, yes, sir, I'm here.
So I don't know. So some people are saying that no sounds is not. Any problem?
No, sir. Audio is not sorted, no, sir. So only the slide was sharing, sir. Audio is not like playing anything yet. So that is the reason it's silent, sir.
Okay. So you can
Yeah.
start now. So you can start.
Yes, sir.
Mhm. So let us start because it's already 7:10 now. We have a long way to go.
Okay, sir. I'm stopping my slide sharing now.
Right. So good evening, everyone. So 31st of October, we have come to the last day of the pink month. And this is a Tuesday evening. So I, Dr. Ghanshyam Biswas, on behalf of the Lung Cancer Update webinar, I welcome you to this scientific meet. So today's academic partners has been AstraZeneca, Dr. Reddy's, 4-Base Square, and the other one I forgot. So, okay. Siddharth?
Sir, it is Wembrace Healthcare.
So you could not give me the right, printout. Wembrace. You could have given me the right printout, no? Okay. So usually expected. So this we just finished last week ESMO. So there are so many updates in lung cancer even. So maybe we can take those in subsequent months. So now we start with the first talk, and that will be a management of EGFR positive NSCLC. So none other than our stalwart Dr. Saurav Kumar Mishra, my medical oncology colleague from AIIMS Bhubaneswar. So in next 15 minutes, so he will talk about management of EGFR positive NSCLC. So over to you, Saurav.
Thank you. Am I audible?
Audible.
Yes. So let me share my screen. So is my screen visible now?
Yes, Saurav, it's visible.
Should I start?
Yeah, please.
Fine. So good evening, everyone. The topic for me today is management of EGFR mutated non-small cell lung cancer. So most common cancer in the world and also in India. Now this is a study from our center, approximately 100 patients of lung cancer, approximately. Please mute your. So if
Siddharth, you mute yourself. Siddharth, you mute yourself. Siddharth, you mute yourself. Siddharth, you mute yourself.
Yes, sir.
So if 100 patients are there in our clinic last 1 year, 75% are adenocarcinoma, 15% squamous cell, small cell is around 7%. So if you see the actionable mutations in the West, EGFR constitutes approximately 17%, 8% is the ALK rearrangements. Then you have other mutations. KRAS is the commonest mutation seen in lung cancer. Now, this is the study from our centers. In 65 patients, if you do only EGFR, ALK, ROS, and PDL1, 51%, that is one half, will have no mutation. EGFR mutations are the commonest, 1/3, 35%. We have also a substantial population of ALK positive patients, that is 12% of the total patients were ALK positive. This may be a selection bias, or maybe we are treating more number of ALK positive patients. Now, of these 65, we have done the NGS testing in around 42 patients. And if you do an NGS testing, the most common mutation is here again EGFR mutation. That is approximately 30% are the EGFR. Exon 19 is the most common, 25%. Exon 21, 5%. Then TP53, next commonest mutation. I am not talking about all actionable mutations. I am talking about in general. If you do an NGS, what are the mutations you see in a lung cancer patient in our clinics? Again, as I said, out of these 42% patients, 8 patients were ALK positive. So very high. We do not know what is the reason. Maybe it is a selection bias or whatever. KRAS is less in our population. Then there are other like BRAF and PTEN, HER2, ROS1 and CMET. So summarizing would be, if you do only EGFR all-cross compared to if you do an NGS, you would identify approximately 10 to 15% of additional actionable mutations. And again, EGFR mutations are the commonest, exon 19 being the major chunk of the EGFR mutation. So most of these patients who are having EGFR mutation at baseline are metastatic disease, having metastatic disease. So first line treatment in our clinic, mostly it is usually a first generation TKI, EGFR, that is erlotinib or gefitinib. Second generation TKIs are also available now and we are using them. Third generation TKIs, osimertinib is the drug of choice for metastatic stage 4 EGFR mutated lung cancer, and this has been very well delineated in most of the guidelines that if you have an upfront metastatic stage 4 adenocarcinoma of the lung which has an exon 19 or exon 21 L858R mutation, you need to give osimertinib in these patients, and this is based on the FLAURA trial. Osimertinib versus either gefitinib in erlotinib in this population, that is those who are having exon 19 deletion or exon 21 L858R. And very clearly there was a very significant improvement in the progression-free survival which was seen across all subgroups. Most importantly, this is the only TKI which has shown a statistically significant improvement in overall survival as compared to first generation tyrosine kinase inhibitors. However, although the OS is also seen beneficial in across all subsets, if you see there is some bit of benefit which is seen much more in the subgroup of patients who are having EGFR exon 19 deletion compared to those who are having exon 21 L858R. Here in the forest plot, the confidence interval crosses 1, meaning that the OS benefit is not that marked in L858R subset of population. However, having said that, the clear-cut PFS benefit across all subgroups and only drug which shows OS across all the subgroups, this is the drug of choice. This is what I was talking to. If you go for a bit of subset analysis, although these were not powered to show differences, we can say that on the A panel, we have seen here the Asian population and compared to the B panel, which is the non-Asian population. And in the non-Asian population, you can see the magnitude of osimertinib benefit is much higher. In the Asian population, the benefit is there till 3 years, and after that, there is some amount of crossover happening over here. The graphs are crossing each other. The other thing here is saying again, the panel C is for EGFR exon 19 deletion. You can see very clearly the graphs are separating in the exon L858R, that is a 21 exon 21. Again, the graph is almost like superimposed over each other. So meaning that L858R population of patients don't do that good with osimertinib compared to the first generation tyrosine kinase inhibitors. If you go for Indian data across first generation, we have got a very similar PFS for the first generation TKIs around 8 to 10 months. That is what we also see in our clinics, and OS of around 10 months, OS of around 2 years. Now, when I was discussing about the progression-free survival and OS survival, and we were trying to dissect out the benefit with exon 21 and exon 19, the relay trial, which compared the combination of ramucirumab plus erlotinib versus only erlotinib, showed a clear-cut improvement in progression-free survival, and which was seen statistically significant both in the exon 21 as well as the exon 19. You can see the PFS of 19.4 months. It is the maximum which we have seen for any combination of tyrosine kinase inhibitors or with single agent or osimertinib at around 18 months or 18.9 months of PFS. So this is a very good combination in some of the patients like exon 21 L858R. We can consider this combination also. And the benefit was seen across all subgroups. So ramucirumab plus erlotinib is a decent option, especially for the exon 21 L858R. Having said that, the osimertinib being the drug of choice in the metastatic EGFR mutated lung cancer, what about the second generation TKIs? We have some data with dacomitinib, which was the Archer study. But the Archer study showed, although there was an improvement in the overall survival with dacometinib, the main problem with this that they excluded patients who had brain metastasis. So you can see here on the right hand side panel that there was an improvement in dacometinib, not that elegantly separating curves as you would see with osimertinib. Plus the design of this study of the hierarchical analysis, actually we did not allow for a formal statistical testing for overall survival. However, dacometinib actually had an improvement in survival compared to gefitinib, and this is again a data for the second generation TKI. Afatinib failed to improve OS compared to gefitinib. Now, the separation of curves, if you see, which is needed for our patient, the clinical benefit, we want to see the benefit sooner. So the flora from the very beginning, osimertinib graph starts separating. With Archer, it is approximately after 6 months. With Lux Long, it's almost after 1 year. So osimertinib brings rapid responses, durable responses. One thing which is unequivocal is the brain metastasis. The CNS metastasis is somewhere osimertinib scores over every other TKI. That is, it leads to improve in intracranial controls, intracranial improvement, progression-free survival, as well as in the systemic progression-free survival. So those patients who are having treated brain metastases, untreated brain metastases, osimertinib has a very good CNS penetration, very good CNS response rate. So unequivocally, when we have stage 4 adenocarcinoma of the lungs with EGFR sensitizing mutations with brain metastasis, no doubt osimertinib is the first drug to be used. The other thing is that these patients will take these drugs for quite a long period of time, so we need tolerability. And we know that the second generation TKIs, especially afatinib and dacometinib, are difficult drugs. Most of the patients will have cutaneous toxicities, and many of them will have significant drug toxicities to lead to drug reduction in drug doses. The flora, however, very clearly shows osimertinib. We have seen good experience. A lot of patients tolerate it very easily, not much of toxicities in our clinical practice. So having said all of this, we know now that we have a drug which has a significant improvement in PFS and OS when used in the first line. So we would like to put our best foot forward. So if you give osimertinib, all your patients are able to get the best drug. However, if you don't give osimertinib in the front line, what will happen is that we'll lose out on 2/3 of the patients will never be able to get osimertinib, because many of them will not have a T790M mutation. Many of them will never get a second line therapy. So considering this, putting your best foot forward, osimertinib may be considered as the best choice in the front line setting. This is what I was telling, that if you start with other drugs, first generation TKI, many of the patients will never be able to get osimertinib to start with. Now, there is a study known as GEOTAG study, which said retrospective analysis, if you use a afatinib first followed by osimertinib, you have a median OS of 41 months. We need to randomized strategy to say that whether this strategy is the right strategy compared to only osimertinib in the front line. So sequencing of EGFR TKIs, that is what I said, best foot forward is what we say. What happens if you have a patient who has a mutation in EGFR and then progresses on osimertinib? What are you going to give? Now we go usually with chemotherapy, but there is a trial, the study, atezolizumab study, in which ABCP regimen has been shown to be improvement in overall survival in the EGFR ALK positive subset, those who have progressed. And so it comprises of atezolizumab, bevacizumab, paclitaxel, carboplatin, and it clearly shows that there is an improvement in OS, although small number of subset, but this is a subset where we can consider this regimen, that is EGFR or ALK mutated patients who progress on the TKIs. So OS benefit was seen with this ABCP regimen. So we have a randomized trial currently going on. Some of these patients who have already progressed on EGFR TKIs or immunotherapy and chemotherapy, we can randomize them and we can give them a new molecule known as the SAR 408701. This trial is currently enrolling at our center. This is a new molecule which is an antibody drug conjugate, and in EGFR subset patients who have already received TKIs, chemotherapies, and immunotherapies may be considered for this study also. So this is coming up now. So summarizing, osimertinib demonstrated clinical and statistical significant improvement in OS in such population. median OS benefit of greater than 3 years sets a new benchmark. FLORA is the first time that an EGFR TKI has translated PFS into OS benefit, and 30% of the patients remained on osimertinib at 3 years. So usually putting the best foot forward is what we choose in our clinics. Thank you.
Thank you, Dr. Saurabh. So now we go to from advanced lung cancer to now early lung cancer. So management of early lung cancer, NSCLC with immunotherapy versus TKI, and Dr. Debapriya Mandal from Kolkata, medical oncologist. So Dr. Mandal, please.
Thank you, sir. We'll start. Please kindly put on my slides.
Oh, yes,
Please share
sharing
my
it.
slides. Okay, so we shall discuss about the systemic therapy options in early and locally advanced lung cancer. Next slide, please. So the management was mostly surgery in early disease and surgery plus chemotherapy for most patients who had a stage 1B or higher disease, and surgery for plus chemoradiotherapy for a select few, and chemoradiotherapy for whoever was not resectable. And right now we have many more options like surgery with immunotherapy, surgery with chemoimmunotherapy, and surgery followed by targeted therapy. Next slide, please. So as you can see in the latest NCCN guideline, there are many options right now, which includes surgery or a localized ablative radiotherapy alone for very early disease, to surgery followed by many choices of systemic therapy as adjuvant. Next slide, please. So these are the approved molecules in early lung cancer. In early lung cancer, we have osimertinib in resected adenocarcinoma lung, and this is based on the ADAURA trial. We also have adjuvant nivolumab, adjuvant atezolizumab, and adjuvant pembrolizumab in patients who had a curative resection, and adjuvant durvalumab in stage 3 lung cancer patients who are not considered candidates for surgery and has received definitive chemoradiation. Next slide, please. So we'll first start with targeted therapy options, which are there in the early NSCLC space. Next slide, please. So we'll first discuss about the ADAURA trial, which was a study with adjuvant osimertinib, which included patients from 1B to stage 3, and they were randomized into osimertinib 80 milligram once daily and placebo. And the primary endpoint was DFS, and there were key secondary endpoints like DFS by overall population as well as stratified by stage, and OS, safety, health-related quality of life. Next slide, please. So ADAURA trial showed that there was significant survival benefit with a hazard ratio, unprecedented hazard ratio of 0.23 in the stage 2 to 3A population, and overall population was 0.27. So there was a substantial absolute benefit as well as statistically significant benefit in terms of disease-free survival. Next slide, please. So we have discussed this, that there was, this is the updated DFS in the stage 2 and 3A population, which shows with a longer follow-up that the significant difference benefit in the DFS is maintained. Next slide, please. And we can see the same thing in the next slide. Next slide, please. If we look at the individual subgroups, you can see that the osimertinib benefit in DFS was consistent across all subgroups, and it was also consistent across clinical stages as per AJCC 8 in 1B, stage 2, as well as stage 3A. Next slide, please. So there was nothing new about the side effects that we see in osimertinib that were reported in the earlier metastatic setting trials. So there were no new safety signals, and osimertinib did not show significant grade 3 or 4 side effects. And so next slide, please. Next slide. So we have the side effects were more, and there were very few grade 3, 4 side effects. Next slide, please. So that brings us to the ALINA study, which was recently presented in the ESMO 2023. In one arm, there was alectinib adjuvant, and in the other arm, it was chemotherapy. Important to note that these were resected lung cancer patients, and in the alectinib arm, there was no platinum-containing chemotherapy. So this is something different from osimertinib. And we can see that the 2-year DFS with alectinib was 93.8% versus 63% with chemotherapy alone. And median DFS was not reached versus 44 months. And the 3-year DFS rate was an impressive 88.3% versus 53.3%. And the hazard ratio was very significant at 0.24. So there is about 30%, even more than 30% difference in disease-free survival. Next slide, please. That brings us to the immunotherapy options in early lung cancer. So what is the rationale of giving immunotherapy early in the course of the disease? There are a few hypotheses. One is that the antigen presentation in early disease is greater than metastatic disease. There is low chance of tumor clonality and intratumoral heterogeneity that arises later with more exposure to treatment. Also, the tumor infiltrating lymphocyte expression, CD8 plus T cells and dendritic cells are better in early stage disease. PD-L1 positivity is also hypothesized and to be better in early stage disease. Early stage disease has also more support from interferon signaling and chemoattractants. That so the responses or the treatment benefits that we are going to see with immunotherapy is hypothesized to be more in early stage disease than metastatic disease. Next slide, please. So first we'll discuss about pembrolizumab, the Keynote 671 trial. In this study, in patients who had stage 2 to stage 3B with a single station 2 who are considered operable by a multidisciplinary team, were randomized to either a pembrolizumab containing neoadjuvant therapy arm, which was pembrolizumab with a platinum containing doublet chemotherapy, or only a platinum containing doublet chemotherapy plus placebo for 4 cycles, followed by surgery. In the pembrolizumab, there was 13 more cycles, completing 1 year of total pembrolizumab, and in the surgery arm, it was placebo. The primary endpoint was event-free survival and OS. And key secondary endpoints were major pathologic response and pathologic complete response, as well as safety. Next slide, please. So major pathologic response, which is defined by the ISLC in neoadjuvant lung cancer studies, has less than 10% of viable tumor cells. In the pembro arm, it was 30.2, and in the placebo arm, it was 11%. And pathology complete response was 18% versus 4%. Next slide, please. there was significant improvement in evidence-free event-free survival with pembrolizumab. And that brings us to the second option, durvalumab and neoadjuvant chemotherapy, the AEGEAN trial. In the AEGEAN trial, durvalumab was given with platinum-containing chemotherapy for 4 cycles prior to surgery, and there was durvalumab for another 12 cycles after surgery. And in the other arm, it was platinum-containing chemotherapy alone, followed by surgery, followed by placebo for 12 cycles. The primary endpoint was pathologic complete response and event-free survival. And secondary endpoint was with major pathologic response. Next slide, please. So pathologic complete response was 17.2% versus 4.3%, and major pathologic response was 33.3% versus 12.3%. And there was, at 24 months, there was a 11% difference, 63.3% versus 52.4% in terms of event-free survival, which was statistically significant. Next slide, please. Checkmate 816 was another study which used nivolumab with neoadjuvant chemotherapy versus neoadjuvant chemotherapy alone, followed by surgery, and then the patients were followed up. And next slide, please. The primary endpoints and secondary endpoints were similar, like other trials. And in this trial, the pathology complete response rate with nivolumab containing chemotherapy arm was an impressive 24% versus 2.2%. The major pathologic response was 36% versus 8.9%. And resection rates were also very high at 83% in the nivolumab containing arm. Next slide, please. So Checkmate 816 also showed statistically and absolute improvement in event-free survival across all stages. And in the 3-year update, the evidence-free survival, the event is maintained. Next slide, please. And immunotherapy in early lung cancer, we have discussed about neoadjuvant studies. Now there are other options. Patients who are not treated with neoadjuvant therapy after surgery and adjuvant chemotherapy, patients who had a stage 1B or higher tumor were treated with pembrolizumab 200 milligram every 3 weekly or placebo. And this was continued for 18 doses or 1 year. And primary endpoint was disease-free survival in the overall population as well as in the population that has TPS more than 50%. Next slide, please. In the overall population, the 18-month disease-free survival rate was 74% with pembrolizumab and 64.3% with placebo. There was about 10% of absolute difference. And in the population which had more than TPS 50%, this was 71.7% versus 70.2%. This is a bit different from what we would expect. And next slide, please. So this is approved for the all-comer without PD-L1 expression in the adjuvant setting. And Empower 010 was a durvalumab study in the adjuvant setting, which again had a similar design. Patients from stage 1B onwards, they were given a platinum doublet chemotherapy for 1 to 4 cycles, and after that were randomized to atezolizumab versus observation alone. And the primary endpoint was DFS, that is disease-free survival, hierarchically, that is that was checked in the PD-L1 positive population first in stage 2 to 3, and then if it came positive, the hierarchical PFS was seen in assessing the patients, all randomized patients and intent to treat population. Next slide, please. So in all randomized patients, which is the primary endpoint, the median Disease-free survival with atezolizumab was 42.3 months versus 35.3 months with observation alone. Next slide, please. And in the PD-L1 positive population, this was not reached versus 35.3 months. Next slide, please. So there is with neoadjuvant chemotherapy, there is no trial, no single trial that has shown that there is in neoadjuvant chemotherapy followed by surgery, there is using survival benefit. Next slide, please.
So Devapriya, so only 2
However,
minutes. So only time over, no?
yes,
Please.
right. I'm approaching the end of it. So next slide, please. So we'll only left with the patients of stage 3 who are considered inoperable. Next slide, please. So that brings us to the Pacific trial, which has recently updated their 5-year data, which was chemoradiation followed by durvalumab or placebo for up to 12 months. And the primary endpoint was PFS. Next slide, please. So as we can see, the 5-year update of the PFS showed that the 5-year PFS was 33.1% in durvalumab versus 19% with placebo. Next slide, please. And the 5-year OS was also significantly higher with durvalumab. So we can conclude that the early lung cancer systemic therapy options are evolving. There is osimertinib is standard of care in EG for deletion 19 and LH8 are patients who had a curative resection from stage 1B to stage 3A. And possibly alectinib will also become soon a standard of care options for ALK positive resected lung cancer. And in the neoadjuvant space, we have many chemoimmunotherapy as well as there are options like toripalimab, which we do not have access to. And in the adjuvant space as well, there are studies which have shown survival benefit with pembrolizumab and atezolizumab. And in the neoadjuvant, we have pembrolizumab, nivolumab, durvalumab, atezolizumab. So there are many options. We have to be rational and careful in our selection of such therapies for such patients. Thank you.
So thank you, Devapriya. So I have a question. So early lung cancer is very difficult to see, no? So you don't get enough patients. Suppose you have put the patient on one of these immunotherapy as a neoadjuvant. So what happens if this patient progress? The surgical chance is gone for this patient.
Absolutely true, sir. That's why I think very important to have a multidisciplinary approach here and be very cautious in selecting patients. And it's always difficult that trials included some of the stage 3 patients who are considered operable, but with those patients who have medicinal node positive with inadequate response, there is always a chance of not being operable. And it's important to note that even in the studies, the percentage was around 15%. So one to two patients in 10, even after neoadjuvant, we might be inoperable. So that's the concern. Yes.
Thank you. So now we go to the third presentation by Dr. Jogmaya Patnaik. So our medical oncology colleague from Odisha, she is working in KIMS. So she will have a talk on osimertinib real world evidence as a first line therapy in NSCLC. So over to you, Dr. Jogmaya.
Good evening all, and thank you, Ghanshyam sir, for thank you Indian Association of Oncology for providing the opportunity, and thank you AstraZeneca. So I'll start sharing my screen. I hope it is visible and my screen is visible and I'm audible.
Not. You are audible, but the screens are not visible.
Is it visible now?
No.
Anita, can you help out?
Yep, is there now. Go to the first slide, Jogmaya.
Yes. Yeah. Can I start?
Yeah, please go ahead.
After going through a lot of discussion and newer developments in lung cancer, now we go back to our friend, which is osimertinib, obviously. We see a lot of randomized control trials, and we find that the randomized control trials, they give us a robust evidence to use the molecule in the clinical practice. But nowadays, we are also facing a lot of challenges to use these drugs in real world or in clinical practice. Therefore, the real world evidences are also coming into picture, and a lot of molecules they are coming with the data of the real world evidence. So we will discuss today real world evidence of osimertinib as first line therapy in EGFR positive metastatic non-small cell lung cancer. So the first study which looked at it is the FLORA study. FLORA is a double-blind placebo-controlled double-blind trial, and it included more than 18 years of patients with good performance status and EGFR positive treatment naive patients in which stable CNS metastases were allowed. And in this, two arms were there. One had osimertinib in the standard dose, continued till progression, and the comparator arm had a gepitinib or erlotinib as the first line TKIs, other EGFR TKIs, which were compared along with osimertinib. The primary endpoint was investigator assessed PFS. Secondary endpoints were overall survival, objective response rate, duration of response, disease control rate, depth of response, etc. Overall survival was also a key secondary endpoint, and it has also an exploratory endpoint of post-progression efficacy. So the baseline characteristic in between the two arms were well balanced. More female patients were there in both arms compared to the male patients, almost 2:1 ratio. And the median age was 64 years. Asians represented the higher population compared to non-Asians, and never smokers and former smokers were more compared to current smokers. Stable CNS metastases were allowed, and around 20% of the patients in both arms had CNS metastasis, and most of the patients were metastatic and adenocarcinoma. Exon 19 deletion where patients were more compared to the exon 21 mutation or L858R mutation patients. So when we saw the FLORA primary endpoint, that is investigator assessed primary investigator assessed progression-free survival, it was 18.9 months in the osimertinib group and 10.2 months in the standard comparator EGFR TKI arm. And the hazard ratio was better, and it favored osimertinib in almost all the subgroups, be it male or female, age at the presentation, race, smoking history, previous CNS metastasis or not, and EGFR mutation, whether it was assessed by any method, either by ctDNA or by any tissue sample or the NGS method, and it was centrally confirmed or not. The curves were separated, as Dr. Saurav in the first presentation told that in FLORA, the curve started separating from the first 2 weeks itself, first 1 month itself. So the median progression-free survival was almost 8 months higher in the osimertinib group compared to the other comparator TKIs. And the overall survival also was higher. That means in the range of 38.6 months in the osimertinib group and 31 months in the comparator group. The similar benefit as seen in the PFS was also seen in the overall survival Kaplan-Meier curves. So it was seen that the improvement in the progression was also shown in the improvement of progression-free survival was also seen in the improvement in the overall survival. Osimertinib also is a very important drug for the treatment of brain metastasis patients, and FLORA is the most important trial which included stable brain metastasis patients. As Dr. Saurav has previously described, there are a lot of trials which, like Archer trial, for dacometinib, they have excluded the brain metastasis patients. So in patients who had brain metastasis also, the for the CNS PFS, there was an early separation of the PFS curves. So the hazard ratio for CNS progression was 0.48. That means there was the CNS progression was prevented by osimertinib by almost 60-70%. So there is almost 50%, 52% reduction in the CNS progression compared to be precise, as per the FLORA trial. And the curve started separating very early. That means the CNS benefit also, along with the overall progression-free survival, the CNS progression-free survival also was much better in the FLORA. So the probability of experiencing a CNS progression event in the absence of non-progression or death was consistently lower in osimertinib, rather than any other EGFR TKIs. At 6 months, in patients who had osimertinib, only 5% of the patients having CNS involvement, they progressed, compared to 18% of the patients in EGFR TKI comparator. Similarly, at 12 months, in osimertinib arm, 8% patients progressed in CNS compared to 24% patients in EGFR TKI comparator arm. And if we see the safety profile, FLORA showed osimertinib is a very safer drug, and there is no extra indication or extra toxicity compared to the other EGFR TKIs. And all grade 3, grade adverse events were almost similar. And there are no specific osimertinib associated side effects which were noted, though we see osimertinib in real world can cause some cardiac comorbidities, can cause thrombotic complications, can cause some lung fibrosis. So these are seen in real world, but in the trial, there were no extra safety signals compared to the EGFR TKI comparator arm. So the FLORA concluded that osimertinib had resulted significant improvement in PFS, overall survival, almost 70%, 60 to 70% better PFS compared to the EGFR TKI, and also around 52% improvement in the CNS progression. And it is a very safe drug, and safety profile was similar to other EGFR TKI, no extra safety signals. Median overall survival reached up to around 38.6 months compared to the other EGFR TKIs, which reached up to around 31 months. So what do we want to know more after this FLORA trial? Definitely, there are unanswered questions which should be answered, like, is this finding is applicable in the real world? Is this CNS improvement is applicable in the real world? And if the patient median age group is 64, if I diagnose a patient at the age of 70 or 70 plus, then will this be applicable to that patient? So that information we get from the real world studies. So as we have also discussed that though the randomized controlled trials, they're highly controlled population. So in those controlled population, we find robust data, but its representation into the real world is usually less. So therefore, the real and sometimes there is discrepancies between this randomized controlled trial results and the real world evidence what we find. So therefore, it is always better to get a real world evidence if the drug is whether the drug is working or it is not working in the real world in real population of patients. So there are few studies also of osimertinib. We showed that the FLORA trial results can be replicated in the real world also. So this study we will discuss that FLOWER study, OCFAC study, Mayo-Corner study, Spanish study, and one HOT 2002 study. These are mostly observational and some are retrospective, some are prospective studies, and they are carried out at different centers. So, and the PFS, what we see in the real world, they are depicted in very different ways. Like the term progression-free survival can be represented in these three forms. That means time to treatment discontinuation, time to treatment failure, time to next treatment or death. This all terms has been taken as endpoints for detecting or denoting the progression-free survival in real-world studies. So if we see the median PFS of FLORA study of around 18.9 months, the other studies like Flower study, they have also replicated the same. OSIFACT study, Spanish study, all these studies, they have found out that the median PFS of, though the patient numbers were lesser compared to the Flora, the median PFS were almost ranging around approximately that same, 18 to 20 months, like that. So the higher PFS was achieved in a Spanish study. So this is also possible if we see in the real world patients. So all these parameters which we described as a surrogate marker for progression-free survival, they were also found, and the median time to treatment discontinuation for next treatment failure, all these are ranging from 18 to 25 months. So this PFS of Flora study has been also maintained in the other real world studies. Flower study, this Flower study has been first line osimertinib in real world. This is a prospective study, and the median age of this patient was even higher than the Flora study, 68 years. It was conducted in Italy, and this also showed that the median time to treatment discontinuation of osimertinib was 25 months, and the median time to treatment discontinuation in patients who were having with or without symptoms at diagnosis, it is around 18.8 months. Those who are having more than at least 3 metastatic sites, their PFS was around 20 months. Median progression-free survival was around 18.9 months, and the patients who are having this brain metastasis, their progression-free survival is around 13 months. And this overall, the partial response was around 73%, stable disease was around 23%. And important is that these patients had around 30% brain metastasis. Flora had a 20%. These patients were having 30% brain metastasis, and their Charlson's comorbidity index were also higher. They took the score of more than 6, and more than 90% patients had comorbidities of Charlson's score more than 6. These patients majorly have this exon 19 deletion compared to more L858R mutation also. Not only the Flora had very less L858R mutation, around 25 to 30%. They have around 40% patients of exon 21 mutation, which is considered as a poor subgroup compared to exon 19 deletion. So in this group also, in real world, osimertinib fared better compared to the other EGFR TKIs. This study was conducted in Italy. So in this study, they found that diarrhea and skin rashes and paronychia, they were the more common real world problems compared to the other problem. As I told that osimertinib can have some other real world issues or adverse events which can be higher compared to the actual trial setting. So this also confirmed the effectiveness and safety of osimertinib in the real world in Italian population. Another study, OSIFACT study, this is a Japanese study, and it had around 500 plus patients, more adenocarcinoma patients, and their median age was also higher compared to the Flower study. It was around 71 years. Performance status were more than 2 in 16% of the patients. Brain metastasis was similar like the Flower study. It was 31% patients, and this patient had almost equal population of exon 19 deletion and exon 21 mutation. So in that, the overall response rate of osimertinib was 76%. Disease control rate was 94%. So in this also, the CNS median, the PFS, median PFS was around 20.5 months. In this also, the all grade toxicities were around 12.8%. More than grade 3 toxicities were approximately 4.5%, very, very less. And the causes for which treatment discontinuation was done, the major cause was disease progression. It was not any adverse events. So another study is which was conducted. It is a multi-center study. It was conducted in US, Japan, Germany, and China. And in this, the median age of the patients were almost 70 years. 14% of the patients were more than performance status 2. As we know that the lung cancer patients with brain metastasis, there most of the times their performance status is very bad. So this patient had this study had higher brain metastasis. That means 33%, highest among all the studies that we described till now. Comorbidity index was more than 3. And the exon 19 deletion was around 50%. The exon 21 mutation was around 33.7%. And this study, by the interim analysis, it showed that almost 60% of the patient remained on first line osimertinib till the interim analysis were done. And
Jogmaya, so you need to conclude now. So in 1 minute,
okay.
time is up.
So this also had the median time to start the next treatment around 17.9 months. So another study, Mayo-Kono study, this study also showed that the progression-free survival in osimertinib treated population were around 16 months. So another Spanish study also, they showed that there was the progression-free survival of FLORA trial almost maintained. This study was mentioning around 25 months of progression-free survival, and median overall survival had not reached. So can we see that this in older patients, can this be maintained? So there is one study from Japan. This study, HOT 2002 study. Japanese people are known to survive for longer. So this study showed that in 80 years, median age 80 years patients also, osimertinib can show a median PFS of 19.4 months. So it is safe to use this drug in the elderly patients more than 75 years also. It maintains the same PFS compared to the FLORA study. So till now we understood that the FLORA trial PFS, CNS PFS, and the safety profile all were maintained in the real world evidence. So this slide has shown that various TKIs were compared head to head, and in this study also, in this picture also, osimertinib fared better in the setting of PFS compared to the other TKIs. It has shown the best PFS in first line setting in EGFR positive lung cancer population of 18.9 months. Other studies of EGFR comparator studies, they have not shown this much of PFS compared to any other TKIs. So as we know now that osimertinib as a first line gives us a benefit of around 19 to 20 months of first PFS1. It can be continued also after progression if the patient is stable and just radiological or not much symptomatic. Beyond progression also it can be continued. So the overall survival also reaches for around 40 months. The overall survival can reach. So as these studies are replicated or represented in the real world setting also, the NCCN guideline has mentioned that osimertinib can be used as a category 1 recommendation for exon 19 or exon 21 mutated lung cancer patients who are advanced stage. So this is used as the first line indication. So to summarize my talk, real world analysis studies also have shown that osimertinib's benefit are maintained in the real world studies, as we have seen in the extremely controlled randomized controlled trials, and there are no extra safety signals. So used for patients of very specific population like age group more than 75, presence of brain metastasis, irrespective of ethnicity and specific mutation types. So this has demonstrated benefit in real world constantly along with the results seen in FLORA trial. Thank you. Thank you so much.
Thank you, Dr. Jogmaya. So what do you do in a known case of interstitial lung disease who is exon 19 mutated advanced lung cancer? So would you advise osimertinib for this patient? And so have you seen any cardiotoxicity with osimertinib?
No, I have not seen any cardiotoxicity, but I have seen in discussions people have described thromboembolic events, and these thromboembolic events also can be cardiac thromboembolic events also. And first question, sir, I will not use osimertinib in patients with interstitial lung disease. I will find a safer option.
Right, because so one of the Indian papers from Dr. Ullas Batra has shown around 6 to 8% of on ILD. So it's quite high. So probably you'll choose other options.
Yes.
So right. So now we move to the next session, so which will be moderated by me. So managing stage 3 non-small cell lung cancer in real life. So we have Dr. Saurabh Mishra, Dr. Sushant Paikrai, Prashant Kumar Parida, Somya Surat Panda, Dr. Ganesh Subudhi, and Dr. Devapriya Mandal. Please allow me for screen sharing. I think you are able to see my slides.
Yes.
Yes, slides are visible.
Yeah. So 52-year male, chief complaints of weight loss and dry cough. So no significant comorbidities. A chest X-ray showed radio opacity in the left upper and middle lobe of left lung. Perilesional haziness present. Mild bilateral apical thickening seen. So this is the CAT scan report. A large heterogeneously more than 7 centimeter mass with the necrotic component involving the apico-posterior segment of the left upper lobe. And in addition, few sub-centimeter enlarged mediastinal lymph nodes are seen, likely representing a metastatic involvement. So subsequently, a PET scan was done. We showed as a more than 7 centimeter mass with averting the costal and the mediastinal pleura, so making it T4. The mass is averting the arch of aorta and encasing the left upper lobe bronchus, and mind it, so there are right-sided mediastinal lymph nodes, so that makes it N3. So Dr. Ganesh, so a left-sided mass with a N3, so opposite side mediastinal node. So would you consider it a stage 4 disease or stage 3 disease?
Will you consider stage 3 disease?
Right. So now, so what is the importance of segregating stage 3 and stage 4? So why do you want to separate it out, stage 3 and stage 4?
We'll consider curative intent. In this case, we can consider definitive chemoradiotherapy. In stage 4, we have to, it is uncurable disease, right, and accordingly planning of the
right. So CT-guided biopsy was done. It was a poorly defined adenocarcinoma. I can see, so it was positive for TTF1, and so it was basically a T4, N3, and it was a stage 3C disease, so N0. So Dr. Saurabh Mishra, so do you consider stage 3 as a heterogeneous group, or it is a single type of disease?
So stage 3 can still be, like you have shown, A, B, C. So C would be something which would be considered unresectable. Right. And other stages we can still consider for resection. So probably in these stages we can consider some form of neoadjuvant therapy, whereas 3C is something where we would probably consider CTRT.
Right. So coming to Dr. Sushant Paikrai, so what is your take on CT scan versus a PET scan, and how does it downstage or upstage or stage 3 lung cancer?
PET CT has definitely better than, if in my clinical practice, I always consider PET CT better than CT scan. But there in literature, there is written that there is a false positive and false negativity. Negativity is there. So if PET CT around 20% bias, that it will upgrade, and sometimes there is few cases of false negativity also. So only PET CT basically upgrading about mediastinal lymph nodal status. Somehow, if we have that facilities of EPOS facilities and good pulmonologist, then I definitely do a EPOS FNAC, even if I did the PET CT scan.
So we consider every point of view. So PET scan has a good sensitivity and specificity. In our country, definitely some false positive because of tuberculosis, healed lymph nodes can pick up. But definitely now, so majority cities in the country will have a PET CT. So like in our state of Odisha, from 0 to now, we have around 10 PET CT scan in the city. So these are these are different methods. So for viewing the mediastinum status, so mediastinoscopy, then endoscopic ultrasound, reverse. So they have their own sensitivity and specificity. And we know that, so today, though lung cancer is not very commonly seen in stage 1, and Dr. Devapriya has talked about the newer advances like IOs and TKI. So we'll focus today on stage 3 lung cancer. So Dr. Devapriya Mandal, so what is important in stage 3? So why this heterogeneous group has come up importance today?
Stage 3 is important because certain patients with a mediastinal adenopathy can still be resectable. So, and we have to be very careful in selecting a resectable patient versus a patient who is unresectable and should not be given the benefit of neoadjuvant therapy followed by surgery and should go to a chemoradiotherapy option. And,
right. So not like the stage 4 where we are interested in the systemic control. We are here rightly said, Dr. Mandal. So loco-regional control and systemic control is important, and brain is always a sanctuary site for metastasis. So now coming to this patient, so who had more than 7 centimeter disease, and as we discussed on opposite side mediastinal nodes, N3 disease. So Dr. Soumya, so how do you plan your treatment for this patient?
Yeah, so the stage 3 has become very exciting now with the multiple data of neoadjuvant immunotherapy coming up, and also the perioperative immunotherapy, and then there are some adjuvant immunotherapy in the stage 3 as well, and then you have got the CTRT, durvalumab, and Adura and Elina. So stage 3 is not the one which we were seeing earlier, that only CTRT, and of course the Pacific is also there. So, but however, in the real world, because of the lack of overall survival benefit in the immunotherapy arm, and especially unresectable stage 3 lung cancer becoming resectable is still not achievable. So the plan must be there upfront, any stage 3 lung cancer, whether it is operable or inoperable. So patients who are operable, in those cases only we discuss the immunotherapy options, but patients who are not operable, so if upfront, like in this case, it is a stage T4N3, it is not a T4N2. So here in our case, we'll discuss with the thoracic surgeon, but most likely it will be inoperable because of the contralateral mediastinal nodes and N3. So we'll have to go with the neoadjuvant CTRT approach.
Right.
I mean, a concurrent CTRT approach.
Yeah. Right. So Prashant Parida, so our medical oncology colleague from Odisha. So as Dr. Soumya said, so he will right away go to CTRT, and since it is a N3 stage 3C disease, probably surgeons may not have a much role. So what is your take on CTRT upfront versus you put on these patients on some induction therapy and then put the patient on a CTRT?
Bhai, as Soumya rightly said, so multidisciplinary team, at least we should involve a thoracic surgeon, and because it is 3-3, so I'm not going to give induction systemic therapy, whether it is a chemotherapy or chemoimmunotherapy combination. So whatever the options of using immunotherapy with chemotherapy are inoperable. Those who are in cases we are going to operate in future, then only we can give chemotherapy pre-operative or induction chemotherapy along with one IO like nivolumab or pembrolizumab. But in this case, it is 3C. So probably it is not going to be operable in future. I will go with the concurrent chemoradiation rather than the sequential approach or neoadjuvant chemotherapy. So because two of the largest randomized trial shows when compared with concurrent chemoradiation with induction therapy followed by radiation, there was not a benefit. So concurrent chemoradiation is the preferred option here.
So if you see the Pacific trial, Prashant, so these patients have required at least 1/4 of the patients. If you see particularly 26% of patients in the Pacific trial have received 3 cycles of induction chemotherapy followed by CTRT. So induction followed by not RT but CTRT.
Yes. So that was in Pacific trial, but to one of the meta-analysis as well as two other randomized trials, probably they have shown that no benefit of sequential approach. So better to go with concurrent chemoradiation. But in the Pacific trial, and though it was completely differently designed, at least 2 cycles of therapy followed by CTRT. But most of the
therapy
guidelines
is not for all patients. It was only 1/4 of the patient, especially
Yes.
who had a bulky tumor, like more than 7 centimeter tumor. So where these patients have received induction chemotherapy.
Yes. So, but in most of in my clinical practice, I usually recommend concurrent chemoradiation in stage 3C usually. T4 and 3 disease, rather than giving induction chemotherapy. Rarely, if my radiation oncologist colleague request, then only I
Right.
start
So
induction chemotherapy.
this patient was started on weekly Pacli and 3 weekly carboplatin. So after 3 cycles, in the meantime, the patient had developed a hypersensitive to paclitaxel, switched over to nab-pacli. Post 3 cycles, PET scan showed a very good response. And so as I said, so in the Pacific trial, about 26% of total patients had received previous induction chemotherapy followed by definitive RT. You can see, so almost 26% of the patient had received the induction therapy. So after induction chemotherapy, now patient planned for CTRT. So Dr. Ganesh, so now the patient has received weekly Pacli and 3 weekly carbo. So he had a good partial response. So how do you plan your treatment now?
Definitely, we will go ahead with concurrent CTRT.
So what
In
is
this case,
the radiation dose for the patient, and what is the duration, and how do you plan your chemotherapy, the dosing schedule?
concurrently chemotherapy will be given. In this case, paclicarbo was given induction. We can give carboplatin, or we can consider also cisplatin in this case. Usually 1.5 months of radiation, 45 to 60, I think, gray can be given as per the tolerability.
So this is a concurrent. So Dr. Devapriya Mandal, so what will be your radiation dose?
So more recently, we have come to see that going over 60 doesn't help. Possibly, if we have an image-guided therapy in some areas, selected areas, maybe it can be gone as high as 66. For most areas and for most patients, 60 gray dose in 30 fractions, conventional fractions, is the standard.
Right. So now go to Saurabh Mishra. So when are you going to start? So the patient has just completed the induction therapy today. So today is 31st of October. So when are you going to call these patients for imaging and then plan for CTRT?
So usually the patients would have recovered from their chemotoxicities and all induction chemotherapy by 2 to 3 weeks. So by that time, they would usually be fit for the concurrent chemoradiotherapy arm. So that is what we do usually.
Right.
2 to 3.
So Saurabh, any role of sequential? So you think that the patient may not tolerate chemoradiotherapy, so you put the patient on radiotherapy and then subsequently chemotherapy. So would you recommend it in any patient?
Basically, what this study was, the intergroup study, I suppose it clearly showed that even if it is possible, CTRT is the gold standard. If not, you can still consider sequence.
Right. So that is the standard. So sequential chemoradiation is not the way to go. So this is a Kindle study, ASCO 2020. So I was also a part, my center was also a part of this. And I'll just, so this was almost, we dig out files of last 5 years. And since many patients did not have a PET CT scan, and many a times we are in a habit. So suppose you don't have a resident to do in the busy schedule. So many patients of stage 4, which was written in the file. So once we went through this study, so it was a retrospective collection of data, then we found that there are many patients who are into a different stage 3A, B, C, and which were written in the file as an advanced. So that was at least a fruitful work by my team. And then we found out that at least 10 to 15% of the patients which were put into a bracket of advanced disease that were actually a stage 3 disease. Though we did not have much treatment available 5 years back, but still, so this makes it, because you do understand the stage 3 is a different subset of patients. So these studies have shown that so concurrent chemoradiotherapy for an unresectable patient is so definitely the way to go. Suppose somebody is resectable, then definitely surgery plus chemotherapy has the advantage. Otherwise, in the resectable group, so RT alone or sequential chemo RT or only chemotherapy is not the way to go. So you need to put your patients on a concurrent chemoradiotherapy. So any role of Soumya, so before the durvalumab data, so let us go back 5 years back, or still many of our patients, I think 9 out of 10 patients or 8 out of 10 patients may not be affording for durvalumab. So you have finished concurrent chemoradiotherapy, the patient had a partial response. So how do you manage this patient?
Yeah, so the role of consolidation chemotherapy has been looked into. The Hozier study was there, and also the SOAK study is there, where they looked at giving extra cycles of docetaxel and also etoposide and platinum was also looked into. However, that was a negative study. The Hozier study was a negative study, so giving them extra chemotherapy didn't benefit them. Maximum to maximum, you have to complete the CTRT, and the CTRT itself is a very toxic regimen. So I think the durvalumab, the PACIFIC trial was a wonderful one because it had increased the survival in stage 3, which relapse rate is 70%.
Right.
And the extra chemotherapy was not benefiting actually.
So the patient did not benefited. So the trials also showed no benefit. But in real life, so as I said, so 8 out of 10 patients may not be affording for durvalumab either on a self basis or unless and until there's a clinical trial available. So consolidation chemotherapy or radiotherapy even, so post CTRT have not demonstrated no benefit. So 4 weeks later, so patient had developed in the meantime radiation pneumonitis. So the patient was on steroids. So come back to Prashant. So when are you planning to put this patient on a immunotherapy? So patient has developed a radiation pneumonitis.
So, ideally, because according to the PACIFIC data, the patient should be included prior to 6 weeks. That means before 42 days.
Right.
But because this patient had pneumonitis, and durvalumab is a drug which is known to cause pneumonitis, so based upon the trial data, it will be difficult to include. But for me, if we can treat his pneumonitis and he will be asymptomatic for that only, we can start. Otherwise, starting durvalumab before, according to the PACIFIC data, it will be difficult in this scenario.
Right. In the trial, PACIFIC trial, you can see, so as rightly said, so within 6 weeks, even there are patients who are just they recruited on day 1 of post CTRT. So Ganesh, since we are a part of the phase 4 of this PACIFIC protocol, so that we had 9 patients. So you can just share your experience with durvalumab post CTRT.
Post CTRT durvalumab, our patients actually do well. There is usually to start durvalumab, some of the patients developed pneumonitis. After giving durvalumab, patient well tolerated. So overall, so patients are doing well.
Right. So it was basically the PACIFIC study was a phase 3 randomized double blind. So it was a placebo control because there was no standard of treatment post CTRT. So durvalumab 10 milligram per kg 2 weekly up to 12 months. And it was a 2:1 randomization. And these were the co-primary endpoints and key. So you can see 191 patient had received, that is 26% of the patient have received induction chemotherapy. So now, Sushant, so what do you have to say? So last year we had a 4 years, 5 years, now 5 years data in a stage 3 lung cancer. And at 5 years, you can see an OS of 43% versus 33%. So what is your take?
Already that I convinced the data. Already I have used it as a post CTRT one patient, and this is just if the response is in that patient post CTRT only 15 to 20% shrink of that tumor mass. Still the mass was persisting, not a resectable mass, and gave durvalumab. Patient survived better, but somehow due to some logistic reason he discontinued. But I am very much impressed to give very high risk stage 3 cancer, lung cancer. So it is okay, thumbs up for that durvalumab.
Right. So this is the only drug probably we have approved after all failure of consolidation. So first and only approved IO to demonstrate almost 43% of OS at 5 years. And similar is the PFS. So first and only approved IO to show sustained and durable PFS of 33% at 5 years. So this is, so be it a squamous, be it a non-squamous. So would you wait? So Devapriya, would you like to do a PDL status and then decide to give durvalumab or all comers?
No. I would recommend it for everyone who can receive it, irrespective of PD-L1 status.
Right. So Soumya, so now suppose you have
Sir,
done
click
a NGS for this patient, though it is a stage 3, normally you don't do it. Suppose you have done an NGS and it has turned out to be a EGFR positive. So now we know that, so druggable, so if you have a driver mutations, so immunotherapy is rather contraindicated. So what do you do? So you put this patient on anti-EGFR or still consider durvalumab?
That's pretty tough to answer right now
Right.
in 2023. So we had the data of resected lung cancer and not the
Right.
post CTRT. So the FLORA2, I think, will answer that question. If I'm right
Yeah,
on
even
that
if you
part.
see this, the survival one, so probably the EGFR positive, though it is on the other side of the divider, but still, but in 2023, you may not be opting for an IO if somebody has an EGFR positive. So better to have put this patient on anti-EGFR. So these are updated OS and PFS. And so this patient was planned for durvalumab. Right. So these are some real life data available. So even in India, we have almost like 140 patients in a phase 4. So this data is yet to be published. So thank you, my panelists, for such a beautiful answering this question. So now we move to a talk by Dr. Bivas Biswas. So I don't know, Bivas was supposed to leave Tata and join Apollo, so he can better say. So Bivas is all yours. So he'll talk on optimal management of first line extended stage, extensive stage small cell, a case-based discussion. So from
Thank you.
GB to BV now.
Thank you, sir. Very good evening. I think there is lots of people, lots of colleagues joined for this webinar. And yes, the disclaimer is that yes, I am leaving Tata. So thank you for this opportunity. I'll share my slide in between. It's nowadays commonly discussed topic, but still a very frustrated one to me. Not much of development happening in this field, even in spite of the development IO. Anyway, let's see what is there in this my slide. So the topic is how I treat extensive stage SCLC with durvalumab, real world experience. I think this is a case-based discussion. So I directly go to the case. Mr. X, 35-year-old gentleman in June 2021, changed his voice, so slowly progressed to aphonia, dysphonia, and the hoarseness of voice. No comorbidity with a smoking history, visit to an ENT surgeon, diagnosed with vocal cord palsy. And then subsequently underwent CT scan, chest, I am sure, followed by the other scan. So the CT chest, this is on 8th August 2021, small, mild, enhancing soft tissue surrounding fibrosis in left apical segment, multiple enlarged conglomerated necrotic lymph node in the left hilar, paratracheal, paraesophageal region. That is very common with small cell lung cancer. Outer pulmonary window forming nodal mass compression of the left pulmonary artery. So mostly it's a nodal disease, very small primary. So based on the CT scan, patient was started on 80, I think from a primary physician that sometime we do see that patient started on ATT even without any proper diagnosis, without any AV demonstration. Condition worsened. Patient had an episode of convulsion in September, started on AED, and a follow-up MRI brain was done. MRI brain 29th October 2021. 2 into 1.9 to 1.7 centimeter, marginally enhancing intraxial lesion in the right temporal lobe with surrounding edema without any mass effect. And there are multiple other substantive small lesion in bilateral temporal and frontal lobe. There is a multiple brain waves. One is the bigger one. So CT chest was repeated. Now there is a swell, proper swell in the left upper lobe with a mediastinal extension and encasement of the left femoral artery. And I'm sure those mediastinal lymph nodes increase and there is a consolidation. So this is a PET scan was done. If this patient comes to me, I will not go for a PET scan. Patient is already extensive say SCLC. I will go ahead with CT scan anyway. Someone has done the PET scan. This is if you see the very large mass of in the left perihellar region. This is the mediastinal lymph node, and the mass is encasing the mediastinum and the great vessels. So these are the lymph node. These are the, I think, parotid disease also. These are the brain mets. This is on the PET CT itself. Histopathology from the lung mass biopsy, small cell pneumoclinic carcinoma, Pedollon score 3 to 4%. I am not sure why the Pedollon score has been done in small cell lung cancer. So the final diagnosis, extensive stage small cell lung cancer with symptomatic brain mets. Next step, brain radiotherapy followed by systemic therapy versus chemotherapy, chemo plus immunotherapy. Definitely this patient required CNS radiotherapy followed by chemo immunotherapy. Let's see what happens. So this is the article on treatment of brain mets in small cell lung cancer. Assuming patient chemotherapy alone is the most commonly recommended first line treatment, but still, if a patient has a multiple brain mets in a small cell, I am not going to start that patient on chemotherapy first. I will definitely going to radiate because small cell is very aggressive and definitely chemoimmunotherapy does have very less penetration in the brain. Symptomatic patient, whole brain RT followed by systemic therapy, chemotherapy, and symptomatic patient with limited extent of brain mets, some expert choose SBRT as an alternative to whole brain. Definitely, if the patient has a single mets, SRS is an option because we can avoid the whole brain RT and the subsequent toxicity. But CNS therapy is definitely required, especially irrespective of symptomatology if the patient has a bilateral multiple brain mets. So this is the chemotherapy trial. We came along long time, and I think most of the trial it shows median OS between 9 to 10 months. The patient was started on chemotherapy, etoposide cisplatin. Radiation therapy also received between cycle 1 cycle 2, 30 grade infection to the whole brain and hippocampal sparing, followed by 9 grade infection to the gross lesion. So this is the primary therapy for extensive small cell lung cancer. We know it's a platinum-based doublet with either carboplatin or cisplatin with etoposide, and now we have recent data on immunotherapy, both atezolizumab and durvalumab. I'll not go into the details. So patient received 3 cycle of chemotherapy, then durvalumab subsequently added because this happened even in patients with OPD who are not decided yet, who has a financial constraint. Lots of time is taken to decide on adding of immunotherapy. So we have seen most of the patient we do start immunotherapy from second cycle, third cycle. 1500 mg every month. And this is the rationale of adding immunotherapy to chemotherapy, synergistic effect, more cell damage to the chemotherapy, more neoantigen expression, PD-L1 overexpression of the cell surface, more PD-1, PD-L1 interaction. So the immunotherapy effects was better. This is the Caspian study. Durvalumab plus EP versus EP, 4 to 6 cycle, up to 6 cycle, followed by maintenance of durvalumab 4 weekly. See, these are the patient was taken, and primary endpoint was overall survival. Rest was secondary outcome. And we have another study on atezolizumab. This is a table showing some basic difference between this IMPAR 133 and Caspian study. Untreated brain mets was excluded from IMPAR 133, but asymptomatic untreated brain mets was included in the Caspian study. PCI was allowed in control arm in Caspian study, only 10% in IMPAR 133. I think over time, from the land, this long back, 5-6 years back, there's a Lancet article, this study that shows that PCI doesn't prolong survival in extensive stage small cell lung cancer, and from then we have also stopped giving PCI. So I think this point is not very much important to me, whether PCI is allowed or not. Up to 6 cycle of chemotherapy control arm allowed in Caspian, but after I think 4 cycle was atezo arm, atezo study, that is IMPAR 133. Again, there is not much of difference between 4 to 6 cycle of etoposide platinum based chemotherapy. So again, this is not a great difference. Cisplatin, yes, cisplatin was allowed in Caspian, but carboplatin only was allowed in IMPAR 1. So there are a few basic differences, but not major difference. So Caspian study inclusion criteria is reflective of more of the real world because we use either cisplatin or carboplatin. Up to 6 cycle of chemotherapy allowed PCI and allowed untreated brain mets. So definitely those are the advantages with Caspian study. But I think the outcome was almost similar. So durvalumab 1500 mg with platinum 3 weekly 4 cycle followed by 4 weekly durvalumab. OS was the primary endpoint. Control arm could receive up to 6 cycle of chemotherapy. PCI is allowed. Asymptomatic untreated brain mets was included. So this is the PFS result, not much impressive, 5.11 versus 5.4. But if you see the 2 years PFS rate, there was much major difference, 11% versus 3% only. So majority of the patients who are progression free at 1 year remains progression free even after 2 years. So at 1 year, 18%, at 2 year, 11%. So still 50% patient of that 1 year period remain asymptomatic at 2 years. So this is a median OS, 12.9 months versus 10.5 months. Hazard ratio 0.7, 30% reduction is there. This is a 3-year OS, 17.6% versus 5.38%, so almost 3 times. So this is one of the, this was the primary endpoint, and the trial met its primary endpoint to prolong the OS. And 17% patients did remain alive at 3 years. Forest plot, all the subgroup did have favor Durva plus CP arm. Irrespective of brain mets, smoking status, performance status, religion, race, and age group. So Durva plus CP was evaluated in the key patient subgroup. Cisplatin carboplatin eligible patient over 65 years, former and active stopper, patient with brain or similar mets. Also had similar benefit. Response rate was higher, 68 versus 58. Duration of response again was higher, 5.1, so almost similar. But if you see that 2-year ratio, there was some durable response in patient in the durvalumab arm, almost thrice of from the control arm. So this is a subgroup analysis. Patient with brain mets, hazard ratio 0.79, without brain mets 0.76, almost similar. So the OS and PFS benefit with first line Durva plus CP are maintained irrespective of brain mets. For the supporting is use over SOC. So follow-up is spent. Patient received radiotherapy total 30 gray, 3 cycle of chemotherapy, 3 cycle immunotherapy. Let's see the PET scan. There's a very good, I think, response. There's only very limited disease. I think look like a complete response also in the brain. So follow-up patient again after 6 cycle of chemotherapy and 10 cycle of immunotherapy, maintenance durvalumab. A decrease in size of the photopenic area in the right parietal occipital region of the brain. Decrease in metabolic inactive minimal soft tissue thickening in the epiimmunity is a primary site and no other active. So I think this look like complete metabolic response. So this is about Imfinzi. There is a durvalumab with chemotherapy. Induction 3 weekly 4 cycle followed by 4 weekly maintenance durvalumab. till progression or toxicity. So this is quality of life measurement, also this maintained. So to conclude from this Caspian study, first line Durva plus EP has shown sustained improvement in OS compared to robust control arm, that is reflective of real world scenario. Durvalumab is the only IO that provides flexibility of choosing cisplatin or carboplatin. Benefit of Durva plus EP was observed across all subgroup, including brain mets subgroup. More than 17% patients on the combination arm remain were surviving even at 3 years. And this combination provided high response rate and demonstrated the ongoing response at 2 years, more than 3 times than the control arm. Durvalumab offers convenient once monthly dosing in maintenance phase and 75 minutes consistent with the previous safety signal. I think I'll stop here. So, to best of my experience, we don't have very much high experience of Durvalumab in small cell because it is not that common, and definitely most of the patients still not affordable for immunotherapy. But whatever experience we have, not that great so far, because we know that small cell is not a cancer where IO does work so better as compared to the NSCLC.
Right.
So
Right.
thank you for your patient listening. If there are any question, I'll be happy to answer. Thank you.
I think, and there's a good program from AstraZeneca 1+1. I think if that can be improved, then there are many patients who can be enrolled. So be aware, maybe a stage 3 or post CTRT, and now we have to pass for gallbladder cancers also. So thank you. Now we move to the panel discussion, which will be moderated by Someshwar Panda, and case-based discussion on difficult to treat EGFR NSCLC patient. So I think Soumya has very difficult cases. I have been a part of his moderation once. So Dr. Jogman, Dr. Dipti Madam, Dr. Rajiv Jena, Chinmay probably has not joined, and Dr. Paulomi Basu. So Soumya, please.
Thank you, Ghansam. Yeah, so are you able to see my screen?
Yes, yes.
Yes. Thank you. So we'll have some discussion on EGFR mutant non-small cell lung cancer patients, case-based discussion. Mostly when you see a EGFR report in your advanced lung cancer patients, then you are mostly relieved because of the EGFR mutation. So here are my panelists. Dr. Jogma is there, Dipti Madam is there, and Rajiv Jena and Chinmay Pani and Dr. Paulomi Basu. Hello. So this is the first case. This patient actually came, and the patient has got a L858R different. And if you look the percentage, it is something like 44.94% for the L858R. So my first question will be to Dr. Rajiv. So in this case, how will you manage? So L858R, do you treat it similarly to a deletion 19, or do you manage it differently?
We means first of all we give TKI, and if the patient is affording, then osimertinib is the drug of choice. Otherwise, can give afatinib or decomatinib also. And L858R mutation is slightly different than the deletion 19 mutation, which is more common in our setting. So deletion 19 mutation patients, they usually have a T790M mutation in 75% of the cases later on when they progress. So here in a patient with L858R mutation, it is better to start a osimertinib regimen beforehand, because we don't know if we would get a chance to treat the patient further.
So Rajiv, I'll cut you short. So what from your ear? I infer that osimertinib is the one which you will go to. So Jogma, one answer. Which one is the one that you will go at in L858R? Jogma is there? If Jogma is not there, then can Dr. Paulomi take it up?
Yes, sir. Sir, I prefer osimertinib first for L858R mutation positive.
Chinmay, can you enumerate what are the differences between exon 19 deletion and L858R? So Dr. Chinmay is not there and Dr. Jugumai is not there.
Right.
Okay. Anyway, we'll move on. So as you told, the patients, they do not respond that well to a exon 21 L858R compared to a exon 19. And so multiple meta-analysis and multiple direct meta-analysis and indirect are there that say that they are more, they're different. So this is one of the papers from Indian authors, Ullas sir and Vivas sir and Kumar Prasad sir, so and Mamsi sir. So they have all looked into how they are different. If you look at the exon 19, they are more in female gender and no history of smoking. But exon 21, they are more common in male smokers. So that is very important learning for residents, that exon 21 L858R is more common in male smokers. And again, if you look at exon 19, how is the pattern of the metastasis? High risk of pleural effusion and lymph node and brain mets are there compared to those with a exon 21 L858R. So a bit of difference. And again, you know that the exon 21 L858R that has got a reduced PFS and reduced OS. So mostly what we use is right that osimertinib you will give. But if you look at the PFS in exon 21 mutations, median PFS is yet to exceed 14.4 months with currently available single agent EGFR TKI. And there is a differential of response. Exon 19, they do well, not that well when it comes to exon 21 L858R. Be it the LuxLung trial or be it the FLORA trial. You can clearly see from the FLORA trial, exon 19 and L858R, it's almost like the hazard ratio are they're touching in the forest plot, they're touching the line of unity. And as decomitinib a bit better compared to osimertinib, and this is the particular one where erlotinib plus ramucirumab has shown that exon 21 L858R. So this is a particular subset where the benefit is well maintained compared to exon 19. So the option boils down that you have to go ahead to a either a single agent TKI like osimertinib, or you can consider a ramucirumab plus erlotinib. And exon 21, they don't do that well compared to a exon 19. So this is the second case. 62-year-old male was evaluated for cervical adenopathy. FNAC was done, and FNAC was suggestive of metastatic polyclinic adenocarcinoma. PET-CT was done. Again, you have got multiple primary in the lungs along with hepatic, splenic, and bone secondaries, and you have got a deletion 19 as well as coexisting T790M, and this is upfront T790M. So Dipti madam, so how common do you see that upfront T790M?
So actually upfront 790M, what we see, it is not very common, but when we see it, then again you have to think about the osimertinib, because it does not respond to usual first line and second generation TKI. And so it is 5 to 10%, whatever you see, is 790M upfront. And the situation when I was seeing it is osimertinib we have to consider. There are some germline testing sometimes when it is upfront present, you have to go for family history and germline testing also.
Right, man. Right, man. So very well said. Upfront T790M is very, very rare. And if it is there, then you have to consider osimertinib, which has got activity in T790M. Again, this is the third case, 40-year-old female, young female, metastatic adenocarcinoma lung. She was diagnosed as a real case, which was initially treated in TMH, and subsequently patient had come to us. So by the time she came to us, she was already diagnosed as a stage 4 EGFR exon 19 deletion and lungs, pleural effusion nodes, MRI brain, there was upfront disease. Patient received a whole brain RT and gefitinib, received till 1.5 years. She received that from 2017 to January 2019, and then PEM-carbo maintenance, PEM maintenance, docetaxel. So almost all chemotherapy and standard TKIs were over, and then patient had come to us, and patient initially received erlotinib and bevacizumab, and then gemcitabine brinolobine, and the patient didn't tolerate that well, paralytic ileus and febrile neutropenia. So by October 2020, 3 years, we thought that the most likely the year is over. We will not be able to salvage her. So this was a tough situation. We had sent again exon 19, it came out, and we started on afatinib from October 2020 to May 2021. We did a PDL1, and PDL1 the score came as less than 1, and this was in 2021. And subsequently afatinib was continued. She did well to some extent. After that, she had progressive disease, when again we did a biopsy, and that time we did a CT guide biopsy from the lung mass. The report came as exon 19 deletion. Again, you have got a T790M, and you have got one BRAF mutation. So if you summarize, these are the summary variant. So a patient had a EGFR as well as T790M, and you have got a BRAF. So my first question will be to Dr. Rajiv. So how commonly do you see, and how what is the importance of the variant allele frequency? How do you treat these patients actually?
The variant allele frequencies means I go through the literature given in the reports. If any trials are going on, or what are the drugs which we can give. Otherwise, for common mutations, we go for like in this case, the T790M mutation was positive, so we can give osimertinib in this case.
And what about BRAF? So you have got dabrafenib and trametinib. Would you consider that as well along with osimertinib, or you would give it only osimertinib?
I am unaware of any trial where we have given both. I would go with osimertinib.
Okay, very right. So you don't have any data to combine a osimertinib plus a dabrafenib and trametinib, though you have got different. So just my question to Polmy, forget this report. If you have got a patient who has got a EGFR, say, variant allele frequency of 40%, and somebody who has got a variant allele frequency of say 2.7%, and do you think that they will have a differential response to the TKI, or it will be similar?
It is variant. If it is variant, I think their response should be less. But if T790M mutation is positive, then osimertinib is my first choice.
No, I'm not asking about the therapy. I'm asking about the prognostic importance because anyway, there is no correct answer to a variant allele frequency. We have not studied that part. That now that the NGS is rampantly going on, so whether HAP itself is of some prognostic importance, so that part is very tough to tell. So you don't have trials right now to look into those areas that only 35% somebody with deletion 19 will leave out the T790M. So it is deletion 19. And somebody with a 2.57%, whether the 2.7% guy will behave bad compared to a 40%, we don't have answer, but we still think that it might be important in the coming time, and it requires some prospective studies to look into that. And again, when we did this patient, we underwent repeated PD-L1, so the PD-L1 came as 30%. So again, my question to Deepti madam, have you seen that PD-L1 being something which was initially less than 1% now becoming 30%?
No, in my clinical practice, usually we are not having much scope to do it, but nowadays we are doing it. And I'm in my practice, I've never seen it is like this, because it happens after use of therapy. I think gradual evolution occurs, but I have not seen in my practice.
So Rajiv, any thoughts on this? So PD-L1, do you expect that it will fluctuate with time, or it will be like? So if you look at the clones, are they like this one is look at the clones, and can you get some hint from this, or do you think that the blueprint study taught us something?
With time, there can be a change in the PD-L1 levels, but I haven't.
Yeah. So again, Rajiv, thank you for input. There is no straightforward answer to that. That whether PD-L1 is like a dynamic one, you have to check again and again. The clones here used was different. It was a 22C3 upfront, and then SPI-263 was used later on. But as you know from this blueprint study, it was published in the JTO that summarized that the 22C3 and SP263 are like a concurrent, so you can use it interchangeably, at least in lung cancer, though you don't have the answer for all the cancers, but you can use it interchangeably. However, I must tell that the initial in 2021 we did it from the pleural fluid cell block, where the PD-L1 yield or the tumor cell yield might be low, and that means the result that the PD-L1 is less than 1%, and one should always strive for a CT guide biopsy and tumor specimen. So again, Polmy, so somebody who is having a EGFR mutation and PD-L1 is suppose say 90% comes to you upfront, patient is treatment naive, newly diagnosed lung cancer. So how will you go ahead and for the treatment?
If the patient is EGFR mutant, irrespective of PD-L1, I prefer anti-TKI. because there are study which showed that irrespective of PD-L1 status, EGFR and means TKI have means more role, it's more benefit.
Absolutely bang on target. So you are very correct on that part, that somebody who is having a high PD-L1 and at high EGFR, it is so if you've got a targetable or a driver mutation, then you target the driver. You don't go to the IO in that case, which was seen in studies. That was in the osimertinib study. They had seen that irrespective of the PD-L1 status, patient did well with the osimertinib. And again, we have got multiple.
If you
Yes,
are
madam.
having a PD-L1 report also before your biomarker report, again you have to wait for that, because if you cannot wait, you cannot use immunotherapy before this targeted therapy, EGFR targeted therapy.
Yes, there's a very valid point and a very important point, that many times what happens is the PD-L1 report comes early and later on the EGFR report comes. So in that case, what you can do is that you can go to the first cycle of chemotherapy and wait for the next cycle. You can see the both the PD-L1 is there and the EGFR report is there, and accordingly you can take a decision. So I
Yes,
think
yes.
that's a very that's a very valid point. Yes, madam. Point well taken. And there are multiple trials that are looked at. There is inferior clinical efficacy with PD-L1 inhibitors in EGFR mutant, and same is in the NCCN, and the guidelines in the ESCO also, the same thing is there. So this is again another female, 40-year-old female, is a non-smoker and diagnosed with a stage 4 non-smoker EGFR exon 19 deletion, was treated with osimertinib. Near complete CR was observed. However, after PFS of 18 months, there are 2 new metastatic bone lesion was seen. Rest, besides that, she was in a very good response. So, Madam, Dipti Madam, so somebody who is having a oligo progression, only 2 new bone lesions, the rest of the lesions are responding well. So, how do you next manage?
We can use that TKI also, because that patient is having oligo only in bone. I think it is better to continue the osimertinib along with bone stabilizing factor. If the patient will be symptomatic, then you can go for any local treatment.
Very good, very good. So that's what the patient was done. Patient was treated with local steroidic RT, and then patient osimertinib was continued. And after that, a patient had a progression. And the same thing, the NCCN also does recommend that if somebody is having only a limited metastasis, you can consider local therapy and continue your osimertinib. Next, so this is my last case. Dr. Rajiv, so somebody with a EGFR exon 20 insertion in 2023 November. So in the, and this is a patient. Of course, this patient came to us in September 2022. At that time, the guidelines were different, and now the guidelines are different. So somebody with the EGFR exon 20 insertion mutation, how do you now treat in the 2023 November?
In my setting, I usually if the patient is affordable, then we can go with amivantamab or mobocertinib. These are few options which have come very recently and can be given.
So mobocertinib, the Takeda has withdrawn its from the FDA. So they have asked for a withdrawal. So mobocertinib is almost out. So in that case, we have got left with amivantamab. So this is the trial, the Papillon trial, which came out recently in ESMO 2023, that amivantamab chemotherapy versus chemotherapy. You have a very good clear-cut winner in the form of amivantamab. However, the endpoint was a primary PFS and not a OS. So in such a scenario, Paulomi, would you like to wait for the OS data, or you will, because this has now got a approval that the amivantamab chemotherapy is better than chemotherapy in first line, which was not there in earlier?
I think there is clear-cut PFS benefit at least 6 months. So I prefer amivantamab. If patient is affordable, then go for amivantamab.
Yeah, so exon 20 insertions, they are not kind of a very friendly mutation, and the patient have do progress very
Actually,
fast.
Soumya, in real world situation, this does not happen because amivantamab is not possible in this situation. Whether you can use platinum-based chemotherapy, because
Yeah, that's what. So amivantamab is not used alone; it is used along with chemotherapy. And right now, most of the patients are not able to afford that. So what we do is that the same chemotherapy is the one we go at. They don't do well that much with exon 20 insertion. And earlier we used even afatinib, and there was some kind of a response to afatinib, but that is temporary and transient. So most of the patients that do progress. So it is we use permutation carboplatin that don't do respond well compared to other EGFR mutations. So it boils down to afatinib and other therapies.
So you can use some insertion site like they can respond to EGFR TKI like AS763 and Y764. Those mutations, they do respond or not?
So there are some, I'll come to that as well. So for right now, exon 20 insertion, as per the ESMO 2023, amivantamab chemotherapy has come into first line. So as madam was discussing uncommon EGFR mutations, that is something we have left out till now. So non-canonical EGFR mutations. So you can plan for afatinib if the patients they do respond well, and you have got data for the afatinib. And coming to the another case, morphology beats NGS, which we had discussed earlier also. This patient was diagnosed with as a EGFR exon 19 deletion, and then patient had a progressive disease, and liquid biopsy was negative. So initially we gave afatinib. So EGFR exon 19 deletion, we gave afatinib for 9 months. Patient progressed, and as happens, T790 was negative. PEM-carbo we gave, docetaxel we gave, and the patient again progressed. And liquid biopsy was done every time. We counseled for tissue biopsy. Patient was not willing, so CT guide biopsy next time we have counseled, and then patient got a small cell histology. So small cell histology, as you know, there is a histological transformation and which NGS might have missed. So how much Rajiv, so how much importance do you think that this thing is that NGS, but we forget doing a CT guide biopsy and looking at the histological transformation, because their NGS will never tell you the histological morphology. So do you think
so I think histology is the most important thing which needs to be seen, and after that comes NGS, which can help us in deciding the treatment.
Right. So very correctly pointed out. So you can have cases where the morphology is the most important. You cannot go to the liquid NGS, and you can miss out the small cell histology, as it happened in our case, which was eye opener, that we have to insist on the tissue guide biopsy every time the patient comes to look at the the morphology, that we are not missing out a small cell histology, and these are the
influence we can do when the biopsy is not possible. Otherwise,
Yes,
you can
madam.
go for biopsy.
Yes, madam. So sometimes what happens is that technically it is possible. Patients don't want to give consent.
Yes.
In that case, it will sometimes is very difficult to convince them. And we did a NGS even in the small cell histology to pick up mutations, and we found out a PIK3CA mutation, and which is a histological transformation neglected entity. 3% or 5% can have that, and PIK3 mutation is still not a standard. So we continued on the chemotherapy. So with that, I conclude my talk, and I thank all my panelists for having such a wonderful discussion, and I hand it back to the organizers. Thank you.
Thank you. Thank you.
Thank you.
Thank you.
Thank you, Rajiv and Paulomi. Yeah.
Thank you, Soumya, and the panelists. So now we move to a talk by VEGF inhibition in NSCLC getting revamped. So by Dr. Srigopal Mahanti. So I don't know, Srigopal has joined SCG or still in some
Last day.
last day. Srigopal. Srigopal, are you there?
Yes, sir, I'm here. Sir.
Please go ahead, no?
Yes, sir.
Soumya.
Again,
this slide ta कर दो slide.
मुझे stop sharing कर दीजिए.
हाँ, stop sharing है नहीं.
है नहीं?
ना. तो ये जी ठीक. Okay, no problem.
So, am I audible, sir?
Yeah, you're audible and your
My
slide
visible.
Please.
Okay, sir. So, good evening, all, and we'll be discussing on VEGF inhibition in NS non-small cell lung cancer getting revamped. So, it's not moving. Yeah. So, way back in 1971, Judah Hockman first reported the concept of tumor angiogenesis, which was not accepted at that time. 1 decade later, which was recognized by all. So this tumor angiogenesis actually occurs by tumor secreting VEGF, the vascular endothelial growth factor, which increases the new vessel formation and subsequently the vessel movement to tumor and increase tumor vascularity. And we know the VEGF works are the VEGF, ligands VEGF A, B, C, D, and it binds to the VEGF receptors, which are types are VEGFR 1, 2, 3. And subsequently, through the downstream signaling pathway, it causes tumor angiogenesis, tumor cell proliferation, survival, migration, and invasion. Apart from the angiogenesis, VEGF also plays role in immune suppression, like VEGF-A causes PD-1 expression on cytotoxic T cells and causes immunosuppression. VEGF-A also stimulates the T regulatory cell differentiation and also increase the CTLA4 overexpression, thereby causing immunosuppressions. And VEGF-A also causes activation of tumor-associated macrophages, particularly M2 cells, which causes tumorigenesis and tumor development. So we'll see some anti-VEGF monoclonal antibody plus chemotherapy in non-small cell lung cancer. First of all, phase 3 trial of ECOG 4599, which looked into addition of bevacizumab to paclitaxel carboplatin in advanced metastatic non-small cell lung cancer. They showed improvement in OS and PFS both with addition of bevacizumab to paclitaxel carboplatin backbone, with higher grade 3 toxicities of neutropenia to the tune of 25% compared to chemotherapy of 16% of neutropenia. Remaining all toxicities were less than 5%. Next, AVAIL studies used this bevacizumab with a different chemotherapy backbone of gemcitabine cisplatin. They used bevacizumab in 2 strengths, 15 mg per kg in one arm, 7.5 mg per kg in another arm, and chemotherapy in different arm. So they found no improvement in overall survival, whereas improvement in PFS was there with addition of bevacizumab with both 7.5 mg per kg and also 15 mg per kg. No difference between the 2 different strengths, but no OS benefit of bevacizumab with gemcis combination. Another phase 3 point-work study, they compared pemetrexed carboplatin plus bevacizumab 4 cycle followed by pemetrexed bevacizumab maintenance versus pacli-carbo bevacizumab 4 cycle followed by bevacizumab maintenance. They found no improvement in overall survival, whereas PFS benefit was significant. And of course, more anemia and thrombocytopenia with PEM-carbo combination, whereas neutropenia, peripheral neuropathy, alopecia more in the pacli-carbo bevacizumab combination. The benefit of PEM-carbo was more pronounced in non-smokers and large cell histology. In pronounced trials, phase 3 trial, they compared pemetrexed carboplatin without bevacizumab versus pacli-carbo bevacizumab followed by bevacizumab maintenance. There was no difference in overall survival or progression-free survival. Then if you look into VEGFR tyrosine kinase inhibitors plus chemotherapy in this NSCLC, there are many phase 2, phase 3 trials looking into this. None of them found any OS benefit, overall survival benefit. Although few like Nexus, Zodiac trial, they found PFS benefit, although it was marginal, less than 1 month, and increased objective response rate. So one systemic meta-analysis, they looked into one trial, like a 20 randomized trial. They found there was a PFS benefit without any OS benefit, with increased grade 3 higher toxicities of hypertension, hemorrhage, neutropenia, with adding VEGFR TKI with chemotherapy. Now, if you look into VEGF monoclonal antibody plus anti-EGFR TKI in this non-small cell lung cancer, so if you see here, there is a receptor crosstalk between EGFR pathway and VEGFR pathway. The same has been found in many studies. They have found this increased expression of VEGFR2 in patients progressing to anti-EGFR TKIs. So this issue has been addressed in few studies like JO25567. They combine bevacizumab anti-VEGF mAb with erlotinib anti-EGFR TKI. So they compared bevacizumab erlotinib versus erlotinib alone and found improved median PFS of 16 months with the combo arm compared to erlotinib alone, which was 9 months. So probably addition of anti-VEGF monoclonal antibody, it delays the EGFR TKI resistance by inhibiting the receptor crosstalk. So common toxicity observed in the anti-VEGF TKI and anti-EGFR TKI and mAb arm was rash, hypertension, proteinuria. Then phase 3 Atlas trial, they compared the maintenance bevacizumab plus erlotinib versus maintenance bevacizumab alone after 4 cycles of bevacizumab plus chemotherapy. They found no improvement in OS, whereas PFS benefit was there with maintenance bevacizumab plus erlotinib with higher grade 3 toxicities like rash and diarrhea. The phase 3 Artemis trial, they looked into the first line use of bevacizumab erlotinib combination versus erlotinib alone in advanced metastatic non-small cell lung cancer with EGFR driver mutations. They found significantly improved PFS with bevacizumab erlotinib combination to the tune of 18 months with the combination, whereas 11 months with erlotinib. The PFS benefit was more pronounced with L858R mutation, where 19 months PFS with the combo arm and 9 months with the erlotinib arm alone. Patient with baseline brain metastasis, they had a longer survival with this combo arm. Then phase 3 relay trial, they compared ramucirumab with erlotinib versus erlotinib alone in EGFR mutated non-small cell lung cancer. There was significant improvement in median PFS, 19 months, versus erlotinib alone with 12 months. PFS, the PFS benefit was significant, hazard ratio 0.59. The most common adverse events was hypertension, dermatitis acneiformis, and transaminase elevation. Majority patients are from East Asia, almost 70%. De novo liver metastasis and less than 65 years old patients in this relay trial got benefited maximum from ramucirumab erlotinib combination, and similar benefit was found with exon 19 or L858R mutations, unlike the Artemis trial. Here we can see all these anti-EGFR TKI plus anti-VEGF mAb trials, where all trials have shown PFS benefit and failed to show any OS benefit. Now we'll see anti-VEGF role in re-challenging osimertinib. So post-osimertinib progression, one trial looked into the anti-VEGF mAb bevacizumab plus osimertinib. They re-challenged osimertinib along with bevacizumab versus bevacizumab plus chemotherapy, and they found that re-challenging osimertinib with bevacizumab that improved the PFS and OS both compared to bevacizumab plus chemotherapy. So toxicity of bevacizumab was seen in both arms, whereas the chemotherapy one has more neutropenia, thrombocytopenia. So yes, so osimertinib can be re-challenged with addition of anti-VEGF bevacizumab. So VEGF monoclonal antibody plus IO in non-small cell lung cancer. The IM power 150 looked into this. They compared atezolizumab plus bevaci plus carbopacli compared to bevacizumab plus carbopacli. The trial showed significant improvement in both PFS and OS with no new toxicity safety signals. The benefit was seen irrespective of PD-L1 status, irrespective of the EGFR or ALK, any driver mutation status. Now, if we see the novel concept of anti-PD-1 VEGF bispecific antibody, which was a phase 2 trial of ivonescimab, formerly known AK112. It's a novel PD-1 VEGF bispecific antibody, was tried first line treatment of advanced metastatic non-small cell lung cancer without any genetic driver mutations. It was discussed in ASCO 2023, and it has shown a promising result. Although phase 2 studies, they have shown the objective response rate to the tune of 60 to 70% in both squamous and non-squamous histologies. The median, the 9 months follow-up, the PFS was to the tune of 60 to 70%, and 9 month follow-up OS rate was 70 to 80%. The grade 3 higher toxicities was 28%, and treatment discontinuation due to toxicity was 6.7%. So this finding has to be validated on subsequent phase 3 studies. So for the present NCCN guideline incorporates the anti-VEGF bevacizumab plus erlotinib or ramucirumab plus erlotinib as a first line option for EGFR exon 19 deletion or exon 21 L858R mutations. So along with chemotherapy, yes, as per the IM power 150, atezo bevaci carbopacli is category 1 option, irrespective of PD-L1 or any genetic driver mutation status. So chemotherapy plus bevacizumab, yes, category 1 recommendation, particularly for PS01 patients and without any genetic driver mutations, PD-L1 positive patients. They got the maximum benefit from the trials. So bevacizumab plus chemo is pacli carbo or PM carbo or PM cis. The maintenance after using chemo plus bevacizumab is bevacizumab alone with pacli carbo combination chemotherapy. If used upfront, bevaci plus pemetrexed maintenance if it's pemetrexed carbo or cis with bevacizumab which used upfront, It's Atezo-Vivasi maintenance as per the Empower trial. So if it's Atezo-Vivasi carboplatin used upfront, Atezo plus Vivasi can be used as a maintenance. Thank you.
So thank you, Sri Gopal. I think so you have brought out so many facets of VEGF inhibitions. Thank you so much. We go to the last presentation of the day. So this is by Dr. Vidya Beldor, who is a clinical director from Forbasker. So we talked about anti-EGFR, and so she will talk about genomic alteration in EGFR and ALK progress in SCLC. So over to Dr. Vidya.
Thank you so much, sir, for this kind invitation. I'm sharing my screen. Is my screen visible?
Not yet. Yes, it's visible now.
Okay. So I will go quickly. So we have seen a lot of sessions, throughout where we have looked into the response rate, that is PFS and OS, be it chemo, be it targeted, whatever may be the line of treatment, you have only so many patients who respond to therapy. It's not like 100%. That is primarily because the disease is highly heterogeneous. So we know about EGFR TKI from the year 2003, and there are several studies where people have looked into meta-analysis in 2019, 2021, and even as recent as 2023. I have put up here the article where we see that although we all know that first line TKI is a very good option for EGFR positive cases, but then if you see how many of them are actually responding to therapy, 60 to 65%. When we say responding to therapy is like when they did not show any disease progression before the first PFS is achieved. And who are actually good responders, nearly 50%, it's like a coin toss. Similarly with ALK scenario, where you don't see that everybody responds very well to the targeted therapy options. So why is that so? Is it something else that is present along with EGFR driver clones, because of which there is no 100% efficacy in killing the disease, which we all know that tumor is highly heterogeneous. So understanding the tumor heterogeneity at the time of diagnosis or at the time of disease progression becomes a very important aspect in understanding the molecular basis or the biological basis of the disease. So we all know about the hypothesis which has been made by many researchers. This is on the right hand side is a classical proportion of different driver mutations in lung cancer. On the left hand side, what happens actually at the time of disease onset? You have certain primary clones, and you also have certain clones which may not respond. And when you put the TKI, due to selection pressure, those which are actually sensitive to TKI will get killed, but those which are not sensitive, they will get the advantage of being surviving, and they outgrow, and then that is what we see as disease progression in broad sense. So when do we advise, or when does generally in our routine clinical practice, what kind of genomic alteration panel we generally offer to the patients as per the standard of care recommendation? So as per NCCN, today we have nearly 14 biomarkers which are important to be assessed at the time of diagnosis for metastatic non-small cell lung cancer. In short words, we call it as a limited panel. Today I am discussing a story between a limited panel of 72 genes versus a broad panel of 1000 genes, or anything above 300 genes, which we all have in the market now. Many different laboratories have broad panels. So what's the kind of advantage one gets, and when do we ask for a broad panel? So often, as soon as it is non-small cell lung cancer, it is the first thing we do is a limited panel. Once you have the disease diagnosed, okay, there is a strong driver mutation, immediately TKI is initiated. Only if there is progression within first 6 months, then only there is a problem. Okay, then let us move and understand more about the molecular basis of the disease. But what happens when we get to do a broad panel upfront. We will understand what type of multiple clones are there, tumor heterogeneity is there. Is there some underlying block in the same pathway that might not allow the TKI to respond well? This may give some important clues to the oncologist to plan better therapy combinations at upfront, which may not be possible with smaller or a limited panel. So, and it also gives us idea about, today we are seeing many cases where earlier it was a rare scenario. Now we see multiple drivers at upfront. And if you target only one driver, then definitely the other driver clone is not going to be sensitive to chemotherapy often. One has to keep that as a secondary target to be addressed at a later point of time. And the other story is at disease progression, definitely there is a clonal evolution, and therefore what we need to do when there is a clonal evolution, how response to targeted therapy options can be planned. This in summary, this approach gives us a better idea to plan the treatment if we have a broader NGS panel. So, sorry. Okay, so in our lab, we have two panels, as I mentioned. This is a collation of information on 160 patients of non-small cell lung cancer EGFR positive, processed on a broad panel of 1212 genes, and then as against another set of 107 patients, which was processed on a limited gene panel. However, it covers everything what an NCCN would ask for. And there was a small proportion of patients where in this 160, they even went ahead to look at a whole exome. So essentially, this 160 is predominantly dominated by people who were on disease progression after first line TKI. And probably a ddPCR was done, and most of them, if they were T790M positive, osimertinib was initiated. And again, the doctors may not want to do further testing because osimertinib is the way to go forward in second line. So, and hence, it would stop there. But these are probably patients where there was no choice for T790M, or T790M is still there, but still the clinician is interested in looking at a broader picture. So this is a summary slide essentially that talks about what type of co-mutations can happen in an EGFR positive non-small cell lung cancer. Predominantly it is TP53, followed by RB1, which is a marker for epithelial mesenchymal transition, that is a small cell transformation. Then we know about the MET amplification, and nearly 10% of the patients are even showing an EGFR amplification as one of the mechanisms of resistance during disease progression. And there is a Richter amplification, which is again a well-known biomarker known in textbooks, that, but it is a very, what you say, if you screened 160, you came across one. So the, it is not so common to call it as a very important one, but definitely NCCN also has documented, and many publications have documented that Richter is one of the mechanisms of resistance to EGFR TKI. Now, when we look at closely all the other genes which are mutated, we know there is a KRAS mutation, but this is not G12C that comes up. It is G12R and other mutations. And I'm showing that in subsequent slides. PIK3CA is one more block. Then we have mutations in DDR pathway. Then we know the BRAF is one of the known. We have seen the previous previous speaker talking about the BRAF V600E mutation coming out as a mechanism of resistance. And there are multiple mutations which are coming in different pathways. Now, understanding these pathways, and if there were drugs present, can we, tailor-make therapy options? This is only when you have tried all the possible standard of care recommendations and the patient is doing quite well, but still you want to save the patient. Then are there other biomarkers that can be added on as a knowledge that can help in planning a better treatment option to the patient? So we see that majority is driven by Wnt signaling, beta, catenin, and SMAD4, TGF beta, and MAP kinase pathway. Then We have a few like STK11, serine threonine kinases are there. Then we have a bunch of mutations in chromatin remodeling, SMARCA4 and others. So essentially TP53 is directly reflected here on the cell cycle pathway. So what kind of a profile we see in terms of different pathways that evolve, or it comes out as a part of targeting a receptor tyrosine kinase. You try to block a receptor tyrosine kinase, you get a mutation in PI3K pathway. You also get a subsequent mutation in chromatin remodeling. Another way is you target this, you get a mutation in TGF-beta and chromatin remodeling. Like this, there are different models which the cancer cell tries to acquire or rather escape the selection pressure on receptor tyrosine kinase blocker and tries to evolve and survive. So if we know the recipe to target these kind of combinations, we will try to save this kind of a proportion of patients who are like 30-40% who did not do well essentially as per the textbook, and probably we need to look at a tailor-made treatment approach. So when we look and when we see, so you see that there are 6 different ways in which you can understand the disease when it progresses. On the other hand, if you did a small panel, you only know so much about the disease. Of course, this is not an apple-to-apple comparison, but nevertheless, if you see the biomarkers, by and large, there are overlapping biomarkers. But the disadvantage here is this is a limited 72 gene panel. You don't get to see everything that happens as a possible mechanism of resistance. And of course, that again boils down to the pathways that comes out as part of this understanding the biology of the disease. So here you see that there are patients where HRR mutations were activated, or they probably were present at the upfront itself at the time of disease onset. It is just that we didn't pay attention to them because there was an RTK mutation and we went ahead treating the patient. Sometimes PI3KCA is also present upfront. It's just that, you know, then the response is not 100% or rather optimal response is not seen. So this is another table to show, I mean, this is just a summary of the count of patients. How many of them actually had these different amplifications from our lab study. So I want to show here that sometimes, you know, along with EGFR 19 deletion and L858R, nature makes very complex scenarios. It tries to mutate another important kinase driver mutation within EGFR. That means there are 2 clones, one with 19 deletion, another clone which has another rare driver mutation, 2 driver mutations sitting together. So when such a thing happens, then also first line TKI efficacy might be not so great. And sometimes you might have KRAS, we have seen, but as I told you earlier, the mechanism of resistance or the rare KRAS mutations which come up are codon 19, codon 146, and codon 12 arginine that comes out. That's based on what we have seen in our lab. And we do see C797S when we treat with osimertinib, that also we have seen in our lab. So this is for the limited panel, what kind of mutations have been observed. Now moving to ALK kinases. So we had very limited number of patients. So ours is like, you know, it's an observational study. It's not a planned study. And who are the people who actually come to do a broad panel NGS is when standard of care options are not there. And when you take EGFR positive NSCLC, you have a long way to go before you actually want to ask a complex biology question. When similarly, ALK by itself occurrence is low, and number of patients with ALK fusions, ALK also has multiple TKI generations available. Unless one has explored all the options, there is no need to come back and look at the biology in detail. And therefore, we probably have less numbers. It could be a selection bias. We had only 2 patients who, so essentially it is like 8% of patients who had, you know, mechanism of resistance mutation due to an ALK TKI. Of course, they had other driver mutations in CTNNB1 and DUSP6. DUSP6 is a protein which is a phosphatase, and it can be both oncogenic as well as tumor suppressor in different cancers. So maybe if it is a driver, we need to think carefully and see maybe it is also driving the disease. TP53 was present in nearly 1/3 of the patients here. And well, we had other mutations as listed out here in ALK mutated non-small cell lung cancer. Thank you for your attention. And I made it a very descriptive story. I'm open for questions. Just one more addition here. Dr. Soumya mentioned, and there was a discussion on the role of variant allele frequency, how one has to take. Coming from a laboratory background, I just wanted to add one point here. The concept of variant allele frequency, what we learn and we understand from the basic biology is that, from the molecular biology, NGS theory and application is, particularly in the tumor tissue profiling, the variant allele frequency is a very relative term. Suppose I can give one simple example. So suppose the needle goes, let's say the needle goes like this and takes one core. You are only picking up this clone and this clone. And probably only this much percentage of tumor mutations are coming out. But suppose the needle went like this, then your VAF will be high because you are picking up a lot of blue cells as compared to red cells. Same is this, so it's a very, very relative parameter. So one has to look into what is the core biopsy size, and did the core biopsy material have everything tumor cells? There was stromal cells or necrosis. All these factors play an important role to even correlate somewhere close to VAF. Dr. Soumya also mentioned that there is not much value add that we get to learn from VAF, but as a relative value add, because the tissue is the same, what we can try to infer from there is, suppose 35% cells had EGFR positive clones, only 3% or 2.8% cells carried a concurrent T790M clone possibility. That means that the disease is probably going through the transformation of that selection pressure to evolve and co-mutate in order to become resistant to first-line TKI. That's a kind of mechanistic understanding one can get. I just thought I will mention this because I come from an NGS laboratory, and I wanted to share this with everyone of you. Thank you.
Thank you, Dr. Vidya. So that was a nice clarification for what is the importance of VAF. And I think so the importance of understanding mutations, resistance mechanism, co-mutations is important. And the well-studied is somebody who has progressed on osimertinib, the difference between an exon 19 and exon 21 mutations, and somebody who has now progressed on the third generation or a second generation anti-ALK. And I think that was a wholesome story.
Yes.
For side.
Yes, yes.
So thank you so much. So at 9:30 p.m. today, so we come to the end of today's scientific event. And I thank all my speakers and all the panelists and the audience, the beautiful audience. At one time it was 167, and still at 9:30 you can see still 84 people are holding on. And lastly, I once again thank the team from International Association of Oncology who has hosted us this lung cancer update today, led by Anita and her colleagues. And I also thank the academic partners, AstraZeneca, Dr. Reddy's, Forbasker, and Wembrace Limited. So I also thank Siddharth Mahanti, my assistant, my colleague, who has at least reached up to all the people. And at least I think we have something to take home back. Thank you so much. Till we meet next. Take care. Good night.
Thank you, sir. Thank you, everyone.